plexus palsy, that terminology has gone away now, for obvious reasons. And so, introduction, the incidence is about 1.5 per 1,000 live births, and usually it is unilateral, as you all know, and bilateral is very rare. And whether the cesarean section can reduce the incidence, the answer could be yes or yes and no. In fact, there are some case reports associated with plexus palsy after cesarean section, and some of the obstetricians, they are trying to say that it could be an in utero injury, and that is why the baby present with the shoulder dystocia. That's an ongoing argument as well. So what are the risk factors? Advanced age, pelvic anatomy, high BMI, primary parity, and if the mother is diabetic. When the birth weight is more than 4 kilos, the incidence of brachial plexus goes very high, and it's typically associated with shoulder dystocia, but breech deliveries do happen to associate with this problem. Forceps delivery, vacuum extraction, and so forth. So we need to know about the anatomy of the brachial plexus to explain some of the clinical as well as the surgical interventions and all that. So it is composed of 5 roots, and the 5 roots form 3 trunks, and these 3 trunks divide into 2 divisions, and they unite again to form the cords, lateral cord, medial cord, and posterior cords. So each cord is ultimately giving the nerves destined for the particular function. So we need to understand the nerve injuries in order to understand how the brachial plexus palsy recovery happens. In fact, the Sunderland classification is the first classification which was explained by Sunderland. This is neuropraxia, axonal and neurotomy. This is not sufficient to explain how the nerve injury recovery happens in most of the cases. So therefore, the Sunderland classification has come, and in that actually, the neuropraxia and neurotomy, there's no change as such, but he has basically expanded the axonotomy. So this diagram should explain what is the Sunderland classification. The grade 1, there is neuropraxia, where there is demyelination of the myelin, demyelination of the nerve sheath. So in that case, there is only a functional problem, functional disturbance, where there is axon and all the endoneurium and all are intact. Only a demyelination is there. But when it comes to grade 2, the axon is, so you can see the blue color, one is the axon, and the endoneurium is not there. But mind you, there is a perineurium is there. And when it comes to grade 3, the axon is not there, and the endoneurium is not there. And sorry, in grade 2, actually only the axon is gone, but the endoneurium is there. And when it comes to grade 3, the axon is gone, endoneurium is gone, but perineurium is intact. So in this case, there can be partial recovery. So we'll come to that. And grade 4 is having the disturbance in the axon, endoneurium, and perineurium, but the epineurium is intact. Right? And in grade 5 is the neurotomy. So prognosis-wise, so type 1 is neuropraxia, it completely recovers. Axonotomy again completely recovers, but neuropraxia recovery is very fast. Axonotomy, the nerve is, the axon is not there, but the axon has to regenerate from the side of the injury 1 millimeter per day, right? So, but it completely recovers. And when it comes to type 3, the the axon is not there and the endoneurium is also not there, but the perineurium is there. Therefore, they will go for partial recovery. There won't be complete recovery. And type 4 and type 5 both are the same, and they are not going to recover. So they need definitely the surgical intervention. So there is another type which is described by Susan P. McKinnon as the neuromyelitis. I'm not going to detail that, so it's important to say that actually. So this is the diagram, and this is the prognosis. So natural history of the obstetric brachial plexus palsy is being described by the Maracas classification. So he has tried to classify it according to the prognosis of the child, prognosis of the infant, depending on the level of injury. So as we know, if you speak to obstetrician, they would say it recovers 90%, 80%, and even if you read our textbooks, it says that's the usual scenario. But this 90% or 80% is true for the Maracas type 1 only. So it is the C5, C6 injury. But when it comes to extended upper plexus or C5, C6, C7 injury, the recovery is about 65%. And when it comes to Maracas 3, less than 50% recovery. So it is span plexus injury with possible recovery. So you have to remember that some of the span plexus do recover partially. But when there's associated Horner syndrome, it's mostly there's basically aversion of nerves and severe disturbance of the plexus. So it needs surgical intervention for the recovery. The natural history is, again, as I mentioned, is debatable. So people, other than the brachial plexus surgeons, they are very optimistic about the brachial plexus palsy, but in true fact, the complete recovery do happen in 32%. And the clinical signs, if in an infant, if the clinical signs of recovery appear before 2 months, they usually recover completely. But if they struggle to recover, there will be some persistent problems, especially upper plexus patients who struggle to recover over 6 months. So they have some persistent problem. So in the history examination, we would like to know the maternal history, obstetric history, perinatal history, and also the basic physical examination to exclude the differential diagnosis like clavicle fracture, humerus fracture, and could be associated spinal injuries and so forth. And also neonatal examination, spontaneous movements, neonatal reflexes, all have to be done. I'm not going to discuss those. And asymmetric expansion of the chest is important to observe because sometimes there can be associated phrenic necrosis, Horner syndromes, and classical postures like waiter stiff deformity, which happens in Maracas 2 with that's a waiter stiff appearance with the classical posture. And we do use the HSC-AMS scale to examine the patient or to express the patient's recovery, especially during the first 6 months. And we don't use the MRC grading for this. And the eye-cover test is to assess the is a provocative test to assess the movements of the upper limb of the patient. And cookie test is used when the child is coming closer to 6 months. You give a cookie to eat so that whether the infant can pass that cookie test. It's a controversial test. Some brachial plexus surgeons are fond of this. And mallet score we will discuss. And passive range of movement after few minutes. Also, we'll be discussing next slides. And so this is the, can you play this? Yes. So this is a terrible test, I guess, right? So, so you close the eye and get the infant to move. So you can see it's not moving the shoulder, and there's no flexion at the elbow. And so that is how you do that. Or you can use a cloth, but in my experience in our country, for some reason, when you cover the eyes with the cloth, the child take it as, especially at the age of 6 months, they take it as they're trying to play with the child. And so this is the scale. So if there's no contraction, it is 0, and if it's full motion, it is 7. And 1 to 4 is the gravity eliminated part. So 1 is contraction, low motion, 2 is half range, 3 is more than half range. And again, against gravity, 5 is less than half range, and more than half range is 6. So this scale is widely used now, and this is the accepted way to assess the brachial plexus birth palsy child. And so we have to examine the shoulder abduction, and flexion, external rotation, internal rotation, in elbow flexion, extension, forearm supination, pronation, likewise. And so we have to serially examine this, and if the child, if the infant is not recovering very well, especially in the elbow flexion part and shoulder abduction, then we have to think about surgery. So this is used to assess in a partially recovered patient, especially the examination of the shoulder deformity in upper plexus palsy patients. So this is how you, so if you come to this, so this one, the scale 1 is no movement, 5 is normal. So between 2 and 3, 2 and 4 is the exact examination findings we have to mark on. So in active abduction, it is less than 30 degrees 2, and 30 to 90 it is 3, and more than 90 it is 4. External rotation 0 degrees. So it is not locked, but it doesn't really move. So it is 2, and less than 220 it is 3, and more than 20. So likewise. So hand to head, hand behind the head, and hand to mouth, and hand behind the back. So these are the basic 5 tests in the original mallet score test. And so this child, so his short abduction is about 2, so it's about 3 actually. External rotation is about 2, and hand behind the head is difficult, it's about 2 again. Hand to mouth, that is Trumford sign, it's about 2 again. And hand behind the back. So it's again difficult. So that's how you assess the, yes. So electrophysiology is useful in this kind of injury. But initially, there's no point doing it. You have to wait at least 3 weeks, because the collagen degeneration has to take place. So better do, if you want to do a electrophysiology test, can do after 3 weeks. And it can answer some of the questions, but this is again highly controversial. In Sri Lanka, in actual fact, the electrophysiology test is not happening up to the standard, because it needs about 1 hour to do, really assess an infant. And so in the brachial plexus centers, there are separate neurophysiologists for this purpose, but in our country, very few neurophysiologists. And because of that, we don't get the real assessment. So some of the surgeons believe that neurophysiological assessment is useless, and but plastic surgeons will believe that it's better to be done. And imaging, so initial period, the X-rays can actually detect the fractures, and ultrasound scan can detect the diaphragmatic paralysis, and also sometimes the radial nerve entrapment in the sphenoid heart. Yes, because there can be a fracture of humerus associated with this kind of traumatic birth injury. And after about a month, so we can do MRI scan to detect the preganglionic root lesions. And in Sri Lanka, I'm not I'm not getting the MRI done because most of the time the MRI quality is not really enough to detect the preganglionic lesions, and we do go by the nerve conduction test. In fact, CT myelography also can help in detecting the preganglionic root lesions. Ultrasound scan of the shoulder is, we are trying to popularize it, and it has to have some kind of experience to do it properly, and to measure the alpha angle and early changes of the glenoid cavity. So after about 1 year before the surgery, we like to have an MRI scan or a CT scan to have an idea about the secondary deformity, especially the shoulder deformity, before going for surgery. So initial therapy, so this is again a bit controversial, but I generally prefer not to harm the injured plexus during the initial 3 weeks, because by trying to do therapy during the first 3 weeks, you are not really going to achieve much. But some believe that you should move it gently, but how gently is a problem. And next 3 weeks, we can go for controlled passive mobilization, and after about 6 weeks, when the plexus has recovered from the original insult, you can go for passive full range mobilization to keep the joint mobile. And there is an enthusiasm about this super splint is in the literature, and I heard that some of the physiotherapists are fond of doing this. So especially in the upper plexus, the latest deformity is shoulder interrotation and the forearm pronation deformity. So the forearm is made supinated, and shoulder is made external rotated and splinted, thinking that that will help the recovery. And I have shared the experience of some of the Indian surgeons, and most of them, they don't do this. And I have tried once, and it's terrible to do it. And patients and mothers, they don't like it to be done in the initial stage. And that patient developed a contracture, a flexion contracture of the elbow. So I'm not doing it after that. I'm scared of doing it, to be honest. But there is some literature, because I mentioned it for the completeness. When the recovery does not occur, right? So especially pan plexus, we cannot expect a recovery. But there could be occasional cases of neuropraxia, but if they are not recovering by 3 months, we have to go for surgical intervention for obvious reasons, because there's no way, even in the West, even in the developed countries, they cannot delineate that there is the level of injury by MRI scan. You can detect the root aversion, but they cannot say whether it is Sunderland 4 or 5 or Sunderland 3 or 4. So it's very difficult. So it's very tricky. So we have to go in and see the plexus and then decide what to do. And extended upper plexus, we can wait for about 4 months for recovery, and upper plexus only, it was initially when I started doing the plexus surgery in Sri Lanka in 2014. The global thinking was we should go in by 3 months, 3 to 4 months even for the plexus. But now it has changed. So most of the surgeons, they wait for 6 to 8 months now and allow the spontaneous recovery to happen. And if there is no recovery, especially in the elbow flexion, anti-gravity, if it is not going beyond the AMS 4, 3, 4, then better to go and explore the brachial plexus and go for reconstruction. So what are the surgical procedures? So there are 2 types of surgical procedures. One is neurotization, other one is muscle balancing surgery. So about neurotization, so when it is not recovering in this time plexus or extended upper plexus by this time frame, we approach the brachial plexus supraclavicularly and metaclavicularly. Usually the clavicle is divided and the whole brachial plexus is exposed, and we identify the injury, and then usually there is neuroma in continuity, or sometimes there can be root aversion, and then the neuroma in continuity is excised and grafted with sural nerve graft. And if there is root aversion, we can think about the nerve transfers like SANTS and SAM is spinal accessory nerve to suprascapular nerve, Oberlin transfer, SOMSAC transfer, not going to go into detail. And we also can take the intercostal nerves, up to 6 intercostal nerves, and also we can house the opposite C7 as nerve donors in case of root aversion. Mind you, there is all 5 roots avulsed. So as a brachial plexus surgeon, I have only the options of SAM-SSN and ICM to intercostal nerve to the plexus distal limb, and maybe I must discuss about the opposite C7 transfer. It is very rare, but it can happen. And when the neonatal brachial plexus is concerned, brachial plexus spontaneous recovery, the patients do completely recover, about 30 to 35%. And the rest actually recover with some deformity. And problem with some of the deformities, especially the internal rotation contracture of the shoulder and the supinator deformity of the forearm, is there is progressive deformity leading to functional limitations. And especially the internal rotation of the shoulder, if you just leave it and if you sit on, it will go into shoulder subluxation and retroversion of the blade and the bone changes. And with time plexus injuries, there can be incomplete recovery, and some of these patients were very limited place for surgery, but they can be helped with some kind of surgical procedure to improve the incompletely recovered plexus. When the recovery occurs but inadequately, the usual scenario in our country as well as in the world as well, the doctors are very optimistic about the brachial plexus palsy, and they just continue to do therapy thinking that it will recover. Right? But especially in the shoulder deformity, when there is interrotation contracture, this goes into a progressive deformity, and sometimes with the against the gravity, against the stiffening joints, you try to mobilize, and you can go into injuries as well. Usually, the physiotherapy alone cannot help these patients, and they need some surgical intervention. So there is Botox injections also coming for these kind of patients. So why do they get this joint deformity? It is because of continuous poor reinnervation and they incompletely recover. Mostly there is cross-innervation and they go into co-contractures. Right? And there can be muscle imbalance and also growth disturbances. And co-contractures, shoulder abductors and adductors do co-contract, elbow flexors, extensors, shoulder abductors and elbow flexors, and elbow shoulder abductors and elbow and forearm flexors. So these are the types of co-contract that is due because of the cross-innervation. Muscle imbalance due to external rotators and internal rotators of the shoulder imbalance, they go into interrotation contracture, and there can be supinator versus pronator muscle imbalance. So in shoulder deformity, there's lack of complete abduction, lack of external rotation, interrotation contracture due to the interrotation contracture, and sometimes there can be lack of adduction. There's abduction contraction and also adduction contraction, very rare. You can develop various types of joint deformities due to the internal rotation contracture if it is not treated. And this is, you can see on the right side, what has happened to the shoulder joint, so retrorotated joint and the subluxed shoulder joint. So nowadays, we like to perform ultrasound scan of the shoulder, especially this applies to the upper plexus patients when they recover incompletely with the internal rotation contracture developing. So it needs to be assessed serial scanning 6 months, 9 months, and 12 months to detect the changes. So we measure the alpha angle and put it in the Waters classification, and this is the Waters classification. And so if it is Waters 3 and 4, we like to perform surgery, especially shoulder muscle balancing surgery. But in the literature, there are a number of surgeries described. But I do perform the Botox injections to internal rotation initially, and then if it is not successful, we go for shoulder muscle transfer. So surgical Botox injections under GA and to pectoralis major, subscapularis, and latissimus dorsi. And we can do the clavicular head of pectoralis major transfer for the lack of abduction. And for internal rotation contracture, I do the teres major and latissimus dorsi transfer to infraspinatus or the theatercubital of humerus. So there's that is a muscle balancing surgery. And so it is kept immobilized for 4 to 6 weeks with the shoulder spica. So you can see in the pictures in the photographs on the upper row, the initial deformity and how it improves after surgery. In elbow, I can get flexion contraction that is basically due to the growth spurt of the foot, and supination contraction because of the imbalance of the supinators and pronators. Pronation contraction is also can happen, but it's not very common. And especially for the flexion, you can have to do the release, lengthening of the biceps and partial release of brachialis and brachioradialis and anterior capsule. For the supinator deformity, we do brachial plexus, biceps rerouting. And pronator deformity, we can do the pronator rerouting. And sometimes if the radial, because elbow radio, proximal radio and joint is dislocated sometimes. And we have to excise the radial head and the biceps transfer to ulna. That kind of surgical detail, and not going to go into detail. These deformities are there. We also need sometimes surgery, like a tendon transfer, sometimes service fusion, and swallow Kapandi procedure. Finger deformities also can be helped with surgeries like operangioplasty and side-to-side transfers. Therapy-wise, passive mobilization to prevent stiffness is very important, and elbow splinting in abduction for co-contracture. So this is actually done as a dynamic splinting. During the abduction, the patient is given a splint to wear to splint the elbow so that the abduction will improve and it will prevent the co-contracture interfering with the shoulder abduction. And also sometimes we give night splinting for muscle imbalance cases, especially for the elbow and wrist deformities. And the therapy nowadays is really for encouraging the active mobilization rather than passive mobilization. And we need to teach the parents about the play therapy rather than physiotherapy or unattractive therapy. So the mother's intelligence and mother's education level matters mostly. And when the patient is recovering, we have to encourage activities like dancing, whatever the dancing, swimming, or martial arts like karate. So especially in karate, there's a lot of all the blocks are with external rotation, very important for boys. This is a possible protocol, and we have been trying to do this protocol in life and the moment. So in summary, complete spontaneous recovery of neonatal brachial plexus injury is probably overestimated. And continuing passive mobilization without understanding the pathophysiology could be devastating to the child. Timely surgical intervention has been the management of neonatal brachial plexus palsy. And surgical procedures are of two main types: neonatization procedures and secondary deformity correction procedures. Some patients will have to undergo sequential procedures to improve the upper limb function. Serious and careful therapy protocols and play therapy would be essential to improve the overall outcome of the surgery. And thank you. I think I skipped to the time.
Yes, thank you, Amila, for that very informative picture on how to proceed with the brachial plexus injury. Any questions? Anybody can unmute yourself and ask questions if there is any.
Amila, thank you for that. We were talking of this implementing a common protocol some time back. So I think these days are very good days to do that, and we might need some elaborations on your protocol. This is kind of like we can work on it when we have less work. It will be good. So
yeah, shall we do it?
Yeah,
so something like this, and we will elaborate on this.
Yeah. So that's good, and I have done some one awareness program on in the Castle Hospital, because I found out a lot of people who come with the babies, they even don't know how to handle the midwives and the staff. They don't know how to handle a brachial plexus injury. So I think that is very important in the neonatal units. They should know how to handle the initial period where a lot of recovery can be, retarded if they do.
Any other questions?
Sorry about that. I lost my connection. So, hello?
Yeah.
You can hear you again. Yes.
Yeah. Let's use this time and start doing things so that everybody in the chain, this is a chain work, a chain reaction. We should start from the neonatal unit and then the rehab units, and then ending up with the plastic surgeons, whatever category of the surgeons. So I'll talk to you on this regard, Amila. Thank you so much.
Okay.
Any other questions? In absence of any other questions, thank you, Amila, for your continued support for training program. And I think we as people who are looking at the rehabilitation, and also we are now getting specialist rehabilitation consultants, in near future. So all of them are in training with us. So good educating program for them. Thank you very much for agreeing to record this and put it in the college YouTube channel. It's free channel, so anybody who wants to revisit it in few days time will be able to get into the CSRRSL YouTube channel and watch the whole program today. Thank you very much, Amila.
Yeah, thank you, Dr. Okay, thanks.
So can we now move on to our next lecture? That will be done by Dr. Sandini Wijeweera, consultant rheumatologist from Teaching Hospital Rathnapura, and she'll be talking on pregnancy and lupus. So can Sandini start her presentation? Over to you, Sandini.
Thank you, sir. Right. And good afternoon, my colleagues and my teachers. And I like to thank the college for organizing these sessions. I hope you can hear me clearly.
Yes, we can, Sandini. Please go.
Yeah, right. Yeah, I'll share my screen so I can move on to the presentation. Is it all right? Can you
Yes,
all? Yeah.
yes, it's on. Can please go. Thank you.
Yeah. So I'll be talking on lupus and pregnancy in the next half an hour or 40 minutes. So I'll be talking over these sections, the introduction and why lupus is scary in pregnancy, and few case reports we have managed here in Rathnapura, and how do you plan pregnancy in a patient with SLE, and how do you manage a patient with lupus during pregnancy. So as we all know, systemic lupus erythematosus is an autoimmune disease, and it has a significant female predominance, 1 to 10 to male to female ratio, and the onset is during the reproductive years. And there's improved survival because of the advances of new medical knowledge, and which has led to increased number of pregnancies. The pregnancy outcomes, fortunately, have also significantly improved. The rate of pregnancy loss has decreased from 43 to 17% according to one study. However, still pregnancy carries a high risk of complication both to mother, to the fetus and to the newborn. Therefore, a multidisciplinary approach is needed with very close medical, that means rheumatological, and obstetric and neonatal monitoring. So why pregnancy is scary in lupus? Because there are 2 lives which are at risk, and pregnancy is known to associated with disease flare even in well-controlled patients. And there's very high risk of complications than in a normal pregnancy, with higher maternal and fetal mortality and morbidity. And there are issues of recognition and differentiation of normal pregnancy and conditions in lupus. For example, the physiological changes can mimic the disease state. And also, there may be diagnostic confusions in preeclampsia and lupus nephritis. And also, treatment choices are limited to a few safe drugs because of the teratogenic effects of many effective drugs we use in lupus. Additionally, there are refractory pregnancy loss associated with SLE and its secondary secondary complications. So I'll discuss two cases. Case 1 is a 28-year-old patient who presented to us with an intrauterine death at 29 weeks of gestation. Actually, she was diagnosed with SLE about a year ago elsewhere, and there were no major organ involvement then. And she was started on, like, initially on steroids, and it was tapered on. Then she was on HCQ. However, it was a very sad story, and she became pregnant, and she was an unmarried lady, so the pregnancy was concealed, and her residence was changed. So she defaulted her clinic, and she stopped taking HCQ and, like, not on any treatment. And her disease flared up, and she was admitted to a base hospital with intrauterine death and transferred to our hospital for specialized management. So on admission, the SLEDAI score was 31. There was proteinuria, lymphopenia, thrombocytopenia, and anemia, and there was vasculitic rash on lower limbs and other skin manifestations as well, skin and mucocutaneous. So the first we delivered the obstetricians. They delivered the dead fetus after induction, and she was given IV methylprednisolone followed by IV cyclophosphamide, and she was put on hydroxychloroquine. She was given hemodialysis, and she was on ICU for about 3 weeks. And unfortunately, she didn't respond to cyclophosphamide and developed pulmonary vasculitis and hemorrhages and succumbed to her illness. And the next case, she was a 20-year-old mother of one child. She claimed previously she was healthy, and the first pregnancy was uneventful. It was a normal vaginal delivery, and there was no issues of hypertension or any other pregnancy-induced illnesses, and there were no former pregnancy losses. And she was found to have high blood pressure, and this became uncontrolled with antihypertensives, and she developed proteinuria and thrombocytopenia at a POF of 22 weeks. And she was diagnosed as preeclampsia, and pregnancy was terminated by hysterectomy because the mother's life was at risk. However, not like in preeclampsia, the high blood pressure, proteinuria, and thrombocytopenia persisted even 3 weeks after the pregnancy. And she then went into acute renal failure. Actually, she was discharged from the hospital and then readmitted. She needed hemodialysis, and also she developed generalized fits. And on the course, there was a net test which was done, and it was positive, 1 in 320. And when looking at the diagnosis, looking at the investigations, there was lymphopenia as well, in addition to thrombocytopenia from the onset of her symptoms. So she was diagnosed with SLE, and because she fulfilled all the criteria as well, and she was started on IV methylprednisolone followed by IV cyclophosphamide pulse according to a Eurolupus regime, and she responded well to treatment. So all in all, pregnancy is a very challenging event. It's a challenge for management, for the clinicians, and it's a challenge for the patients as well. So therefore, pregnancy should be planned in all SLE patients. It should be planned during periods of disease control. And all the patients should be counseled about contraceptive methods. When we consider the contraceptive methods, the natural and barrier methods have a high failure rate. And if the antiphospholipid antibodies are positive, the patients are at a high risk of thrombosis. Therefore, the estrogen-containing contraceptives should be avoided. And progesterone-only contraceptives have like side effects such as osteopenia on prolonged use. So they should be also used judiciously. And the intrauterine contraceptive device remains a viable and safe option for all the patients with SLE. So we have to evaluate before conception about the risks. First, the major organ functions should be assessed to if there are severe dysfunction, pregnancy should be the patient should be advised against the pregnancy. And the disease activity should be assessed. If the disease is stable, then the patient can proceed. If the patient disease is active, the pregnancy should be deferred. And autoantibody profile should be done to evaluate the risks, especially the antiphospholipid antibodies and anti-Rho antibodies. And before pregnancy, the medications should be reviewed and adjusted to achieve optimal control on safe drugs before conception. The contraindications to pregnancy in a patient with lupus, if there are severe pulmonary hypertension or severe restrictive lung disease, advanced renal insufficiency, advanced heart failure, or previous severe preeclampsia or HELP despite therapy, these patients should be advised against pregnancy. And pregnancy should be deferred if there was a severe disease flare within the last 6 months, and there is active lupus nephritis, and there was a stroke within the previous 6 months. And despite all these assessments, patients should be counseled, because even for a patient with well-controlled disease, pregnancy is a high risk. The disease can flare up. And there are higher rates of pregnancy complications than in a normal pregnancy. And there are suboptimal obstetric outcomes as well, like miscarriages, IUGR, fetal deaths. So, and finally, the risk of neonatal lupus syndromes. And the patient should be explained that the drugs should be continued and the disease should be kept controlled with safe medications during pregnancy. So when we consider a pregnant mother who is who has no complications, we have to monitor them very regularly. We have to monitor them regularly and very frequently to assess for any complication development. There should be a close collaboration between the rheumatologist and obstetrician, and monitoring should be more frequent and detailed than the usual standard of care. In each visit, we have to do the physical examination to see whether there's any new development, and the routine laboratory tests should be done. And specific investigations also should be done according to the risk profile of the particular pregnancy. The specific investigations are the antiphospholipid antibodies, which are lupus anticoagulant, immunoglobulin IgG and IgM of anticardiolipin, and IgG and IgM of anti-beta-2 glycoprotein 1 antibodies. And anti-Rho and anti-La antibodies if not done previously, and double-stranded DNA antibodies to see the disease activity and to monitor, and the complements. So it is this is a rough idea of how frequently we should see these patients. So the rheumatologist should see at 4 to 6 weekly, and if there's an active disease or flare-up, then has to see more frequently. In each visit, blood count. Now, there's serum uric acid is associated with high risk of flare-ups, especially renal flare-ups. That's why it is mentioned up here. And urea, creatinine, electrolyte levels, liver function, urine analysis, and urine protein creatinine ratio, complement levels, and double-stranded DNA antibodies. In our setup, it's very difficult to do complement levels and double-stranded antibodies even once, but at least we should try and aim for do them at least once in each pregnancy. And the specific monitoring, positive anti-Rho antibodies. If the anti-Rho antibodies are positive, a fetal echocardiography, which is also not available in our setup, but this is a standard care. And the obstetrician also see these patients monthly till week 20, and then 2 weekly till week 28, then weekly thereafter, and with ultrasound for gestational dating and for fetal anomalies and to monitor growth. So these are the more sophisticated tests which are not available sometimes in our setup. So this is a list of medications which are safe to use in SLE pregnancy. Non-steroidal anti-inflammatory drugs. In the first trimester, it is associated with high risk of congenital malformations, especially renal impairment and premature closure of ductus arteriosus in the last trimester. So it is caution use during the first and second trimester and should discontinue during the last trimester. And steroids become life-saving most of the time, especially because our hands are tied, as we cannot use many drugs, but high doses can lead to higher maternal complications like gestational diabetes. So therefore, we should use the lowest possible dose, ideally less than 10 milligram per day. And pulse therapy is preferred than continuous high dose therapy for acute flares. And fluorinated compounds like betamethasone and dexamethasone, we use them in IU like for lung maturity, and also later I discuss in congenital heart block. So there is some association with impaired psychological development of the child. And hydroxychloroquine, it's a very helpful drug in pregnancy. It reduces risk of disease flares and also congenital heart block and neonatal lupus syndrome. And it's very safe to use in pregnancy as well. Therefore, it should be continued in all SLE pregnancies. And if they are not on HCQ, they should be started on HCQ. Among all immunosuppressants, azathioprine is said to be safe this was assessed in large number of transplant recipients. However, there are some reports of late development delays in offsprings with azathioprine. The dose should be limited to 2 mg per kg per day. We can't go for very high doses. And the late effects in the child should be explained to the mother. Even though it's a probability, it should be explained to the mother. And the antihypertensives, especially with patients with renal impairment, these are the safe ones to use: methyl-dopa, labetalol, nifedipine, and hydralazine. But there are concerns about growth retardation with labetalol and impaired uteroplacental blood flow with hydralazine. However, these are recommended as safe and preferred drugs for hypertension management during pregnancy. So what about the biologics? The data is limited regarding beta cell depleting drugs like rituximab and belimumab, which is not available in our country. And it is assumed that IgG, which is a large molecule which does not cross the placenta in significant amounts until 12 weeks of gestation. So it is better to continue rather than have a flare of SLE. So these are the contraindicated drugs in pregnancy: cyclophosphamide, mycophenolate. If the patient is on mycophenolate, it can be substituted by azathioprine, or in renal cases by tacrolimus prior to pregnancy. And steroids may be used at the lowest possible dose. And methotrexate and leflunomide we don't usually use for SLE per se, but sometimes we use if there are like predominant joint symptoms. So those are also contraindicated in pregnancy. So we'll now look at a few specific conditions in pregnancy. Now, what do we do if a patient comes with disease flare during pregnancy? These factors are associated with an increased risk of SLE flare. One is active disease during the 6 months prior to conception, a history of lupus nephritis, discontinuation of HCQ in pregnancy, and also in primigravidas. So it is difficult to recognize disease flare in pregnant SLE patients sometimes because common lab tests become less reliable. There will be mild anemia and thrombocytopenia even in normal pregnancy. ESR may be like little bit raised sometimes, and there may be proteinuria. And the complement levels usually rise by 10 to 50% in pregnancy. So therefore, they might appear to remain in the normal range despite disease activity. Therefore, the trend of complement levels, the trend of dropping, is more useful than absolute values when monitoring the disease activity. And anti-dsDNA antibody remains very helpful because it is not affected by the physiological changes in pregnancy. So if the titer of anti-dsDNA rises, that means the patient develops and has developed an acute flare. So how do we differentiate preeclampsia? I mean, preeclampsia can occur in SLE pregnancy. It can coexist, and sometimes we have to differentiate preeclampsia from lupus nephritis flare. It might be difficult because both can present with increasing proteinuria, and like the case I discussed, and deteriorating renal function, hypertension, and thrombocytopenia. But if you look carefully, there may be other hematological changes like lymphopenia in SLE, which is not occurring in preeclampsia. So these are the features of both. Usually in preeclampsia, hypertension occurs after 20 weeks of gestation, but in lupus nephritis, it can present in any time during pregnancy. The platelets are low or normal in both conditions. Complements in lupus nephritis normal, low, in preeclampsia can be normal or maybe marginally low. So anti-DS DNA may be absent or may be unchanged. And in lupus nephritis, the theta is rising. Now we are talking about a patient with SLE coming with like preeclampsia here, because that's why the anti-DS DNA may be negative, or if positive, maybe the theta is unchanged. The creatinine may be normal, may be raised. Lupus nephritis, same. Here serum uric acid is elevated in preeclampsia, but in lupus nephritis, it's normal. And 24-hour urine calcium, we don't do this test usually. It's low in preeclampsia and high in lupus nephritis. The urinary sediments are inactive, which as in lupus nephritis, they are active, like there are cellular sediments. Other organs occasionally involved in preeclampsia, like CNS or liver, in help. And in lupus nephritis, there may be evidence of active non-renal SLE, like mucocutaneous, serositis, and like other hematological manifestations like lymphopenia. And preeclampsia does not respond to steroids, but lupus nephritis responds. However, all in all, it will be extremely difficult to differentiate between the two conditions. And to complicate more, they both can be coexist as well. Renal biopsy could help to differentiate, but the biopsy is associated with very high risk of complications during pregnancy. So usually it is not done during pregnancy. So the delivery of the baby may be the only definitive answer, because in preeclampsia, all the things subsides after delivery, but in lupus nephritis, it will continue to the symptoms will continue to persist. So now, if we consider pregnancy in the presence of antiphospholipid antibodies, antiphospholipid antibodies are present in about a quarter to half of patients with SLE. However, only a fraction of these patients develop antiphospholipid syndrome. But even asymptomatic women with antiphospholipid antibodies not fulfilling the criteria of antiphospholipid syndrome have higher rates of pregnancy loss. Therefore, for patients, asymptomatic patients with only persistently positive antiphospholipid antibodies and no prior event, low dose aspirin is generally recommended. Then the obstetric antiphospholipid syndrome, which is defined as recurrent early losses, early pregnancy losses, or one or more late fetal loss, but no history of systemic thrombosis. For these patients, aspirin and prophylactic dose of heparin or low molecular weight heparin, that is enoxaparin, is indicated throughout pregnancy. And if there is prior systemic thrombosis, full therapeutic doses of heparin or heparin should be given throughout pregnancy. If the patient was started on low molecular weight heparin, it should be transitioned to unfractionated heparin prior to delivery. And heparin treatment needs to be continued for 6 weeks postpartum. As we all know, warfarin is contraindicated in pregnancy. So then we'll talk a little bit about pregnancy in the presence of anti-Rho antibodies. And in our setup, actually, we don't do much for these patients even if the anti-Ro antibodies are positive. The biggest issue is the high risk of congenital heart block. Usually the congenital heart block starts to happen between 18 to 24 weeks of gestation. That is when it starts to develop. Usually it's preceded by lesser degree of conduction delays, which may be reversed with early treatment. But it can progress very rapidly. The first rhythm abnormality detected in the fetus frequently is the prolonged PR interval. So these are the tools for early detection of lesser degrees of heart block. These are fetal Doppler echocardiography, fetal kinetocardiogram, and transabdominal fetal electrocardiogram. But unfortunately, these investigations are not available in our country at the moment. So what we do is we screen for anti-Ro antibodies, and if the antibodies are positive, we plan to have the delivery in a specialized unit with good neonatal care to minimize the complications. But this is the standard care done in other countries. The monitoring should be done weekly between 16 to 26 weeks of gestation and bi-weekly thereafter. And if there's a detection of an early conduction defect like prolonged PR interval, the progression to complete heart block is unpredictable. The prophylactic treatment are given if the PR interval remains persistently prolonged. Maternal administration of fluorinated corticosteroids that are dexameters and betamethasone has shown fetal survival benefit in some studies. And hydroxychloroquine, which we all can use, reduces the risk of cardiac neonatal lupus syndrome in at-risk fetuses. And the recurrence risk of congenital heart block is many-folded higher. And hydroxychloroquine reduces this risk by 65%. And in some studies, they have used intravenous immunoglobulin, but it showed negative results. Unfortunately, currently, with all those monitoring and stuff, still there's no satisfactory treatment for established congenital heart block. So this is, I'm sorry, this slide is not very clear. This is what we talked, everything, like most of the things we talked so far, discussed so far. So if we get a patient with SLE who's planning pregnancy, we have to first assess the patient, and if there's high disease activity, we have to control the disease first with the safe and convert the drugs to safest possible drugs in the can be used in pregnancy. And we have to advise on contraceptives until the disease activity is controlled. And if the patient is having low disease activity, then the patient can be changed to safe medications and proceed to pregnancy. And in the early pregnancy, patient should be assessed, if not done already, for anti-Ro antibodies and positive antiphospholipid tests. If it is only SLE and all those antibodies are negative, we can continue HCQ. And if the patient is not on HCQ for some reason, we have to start them on HCQ, as there are no, if there are no other contraindications to HCQ. And some advocate the use of low-dose aspirin, but in all SLE patients, but it is not conditionally recommended to start in each and every one. And these patients should be assessed regularly for disease activity, at least once per trimester. And if the anti-ROLA antibodies are positive, and if there's no history of neonatal lupus in the past pregnancies, HCQ can be continued, and serial fetal echocardiograms if the facilities are available. If there's history of neonatal lupus, then again HCQ, and the fetal echocardiogram should be done weekly. And if the fetal echocardiogram is abnormal, then the dexamethasone or betamethasone can be tried. And if the antiphospholipid antibodies are positive, but there's no antiphospholipid syndrome, low dose aspirin is recommended. But heparin is not indicated. If obstetric antiphospholipid syndrome is there, low dose prophylactic heparin is indicated. And if there's thrombotic antiphospholipid syndrome, therapeutic heparin is indicated. So in summary, pregnancy in the setting of SLE remains a high-risk situation. There can be disease flares, preeclampsia, fetal loss, prematurity, intrauterine growth rate retardation, and neonatal lupus syndromes remain the main issues. And multidisciplinary care with close monitoring is essential for good outcomes. And active disease at conception is associated with adverse maternal and fetal outcomes. Pregnancy should be planned at times of disease quiescence with effective use of contraception. And all patients who wish to become pregnant should undergo preconception assessment prior to planned pregnancy. And specific monitoring and treatment protocols are required in high-risk situations, such as presence of specific antibodies. There are safe treatment options exist and should be appropriately used for disease activity during pregnancy. Thank you.
Thank you, Sandini. It's a very comprehensive, well laid out lecture. I think it's very informative. We have one question in the chat box which asks why the dexamethasone are not given in the third-degree heart block when it's there. We give it for sort of prevention, early PR prolonged, but first degree and secondary probably brief course. Why is the third-degree heart blocks are not given dexamethasone?
Yeah, it is actually it is contraindicated in third-degree heart block. One thing is, I think it will not reverse the third-degree heart block. And other thing is, now there are other risks associated with dexamethasone also, like late development, like delays and those things. Since there are no good evidence for use of dexamethasone, that's why it's like contraindicated. I couldn't find any other like specific reason for that, sir.
Okay, right.
Even,
yeah, thanks. So, any other questions? Anybody can unmute and ask questions if there are any. Okay, in absence of any other questions, thank you, Sandini, for joining us from all the way in Rathnapura, and pleasure to have you in this program. I think having on Zoom, I think, makes you all also closer to us because
Yes.
we get all the way to Colombo most of the time.
Yes,
Thank you, Sandini. It's great to have you.
thank you very much, sir. Thank you.
So just before starting on our next lecture, I would like to first of all thank Dr. Chiranthi Liyanage for organizing and hosting this event. And thank you very much, Chiranthi, for doing it and coordinating the program. And also all the speakers again for your contribution. And just a reminder that our college annual sessions will happen on 5th and 6th of December as a total virtual program. We have a very comprehensive program with a lot of foreign participants coming in. It will be free for all, but will need prior registration. So closer to the event, look at your social media and other ways of Facebook and all the medias to see how to get registered. You need a registration, prior registration, but we'll let you know as closer to the event how to do that. So keep your dates free, 5th and 6th full day program. Very interesting and comprehensive program covering part of rheumatology as well as into the rehabilitation of common rehabilitation problems. So I would like to now invite Dr. Dineshika Suriyarachchi, Senior Registrar from National Hospital Sri Lanka, to give the case-based discussion titled Great Masquerader. Thank you. Dineshika, you can start off now.
Good afternoon, everyone. Thank you so much for the introduction, sir. A masquerader is someone who is in disguise. As we all know, tuberculosis has been a great masquerader in medicine history. TB can mimic many clinical presentations, raising a significant diagnostic challenge. Likewise, there are a whole new set of masqueraders in our clinical practice emerging nowadays. So I am going to talk about one such mimicker we recently encountered with. So starting with the case, our patient is a 35-year-old female, a medical officer from Colombo with a past history of well-controlled hypothyroidism and dyslipidemia. She presented with a history of fever of unknown origin for 23 days associated with painful lymphadenopathy, headache with vomiting, arthralgia, and myalgia. She had high-grade intermittent fever spikes greater than 102 Fahrenheit associated with chills. There was painful lymphadenopathy localized to her cervical region without any B symptoms. She complained of severe generalized headache with vomiting, but there has been no history of seizures, behavioral changes, or visual symptoms. There was no acute synovitis or morning stiffness. Physical examination revealed an acutely ill patient, febrile, with a transient blanching skin rash over her trunk. There were firm, mobile, smooth, tender bilateral cervical lymphadenopathy as well. There was no neck stiffness. Apart from that, her examination findings were normal. So going back to when it all started, initially she got admitted with acute febrile illness that has been going on for 9 days duration. Similar fever pattern along with painful lymphadenopathy. No history of sore throat or skin rashes or no other system involvement. Documented physical examination findings were normal except for the fever and the cervical lymphadenopathy. So she underwent investigations for fever of unknown origin, and a lymph node biopsy was performed. IV broad spectrum antibiotics, day 8 completed, and she went home with no cure or a diagnosis on day 16. And then she readmitted on day 23 with a bunch of investigation results and ongoing fever. So in summary, our patient is a 35-year-old lady doctor presenting with intermittent fever for 23 days, associated with severe generalized headache, vomiting, and painful lymphadenopathy and arthralgia. She was febrile, looking acutely ill with tender cervical lymphadenopathy and a transient blanching cutaneous eruption. Looking back at her investigations, her blood work showed leukopenia, anemia, and thrombocytosis with high inflammatory markers. Lymph node biopsy report showed necrotizing lymphadenitis with the possibilities of Kikuchi's or SLE. Interestingly, her ANA titer was high and dsDNA was negative, but she didn't have any other clinical features to suggest SLE. Her past investigations were negative for a possible infective etiology for fever of unknown origin. Cultures were negative. Pulmonary TB was excluded. Viral studies were negative for ongoing infection. Imaging findings were consistent with the clinical finding of localized cervical adenopathy. When comparing the past investigation with the current investigation, we noted that she has a clear trend of developing leukopenia, anemia, and a relative thrombocytosis, as well as her inflammatory markers, especially ESR, was persistently high. With this clinical background of our patient and the available investigation finding, we came into several differential diagnoses. One differential diagnosis was Kikuchi's disease. The second one was the possibility of an SLE flare. And the third one was possibility of adult onset Still's disease. She had severe headache. Severe headache was suggestive of possible cerebral involvement. All these differential diagnoses can cause headache, and it raised the possibility of early macrophage activation syndrome as well. Her thrombocytosis is more likely to be reactive in nature at this point, since we couldn't explain it by our differential diagnosis. We went ahead and investigated her further on this regard and found that she was having rising trend of inflammatory markers and a relative drop in fibrinogen. According to the 2016 EULA-ACR criteria for diagnosing macrophage activation syndrome, other than high ferritin level, low platelet, elevated AST level, and elevated triglyceride, and low fibrinogen, the diagnosis of macrophage activation syndrome can be supported by elevated LDH and G-dimer levels as well. So she met the criteria of macrophage activation syndrome at this point. So because of that, we started her on IV methylprednisolone. First pulse was given after a multidisciplinary discussion on day 23. So what happened next? The next morning, she became acutely breathless with high-grade fever, tachycardia of 140 beats per minute, low oxygen saturation with reduced bibasal air entry with left side dull percussion node. There was a transient mobiliform erythematous rash on her back and lower extremities as well. So what could be the possibilities for her acute breathlessness in this setting? We had several possibilities. Whether this is SLE and pulmonary embolism, macrophage activation syndrome and myocarditis, or whether she's septic. So we investigated along these possibilities, and ECG suggestive of sinus tachycardia, troponin I was negative, and there was no evidence of transthoracic evidence to suggest myocarditis or pulmonary embolism. Ultrasound chest suggested a left side mild pleural effusion, hypoechoic bilateral lung bases, suggestive of either atelectasis or a thin consolidation. Her ABG revealed respiratory alkalosis, and the G-dimer level was high, and the repeated ferritin was 1100. And this investigation finding suggested a possibility of acute pulmonary embolism. But her symptoms got worsened over the next few hours, needing ICU care and invasive ventilation. Fever continued. While awaiting the CTPA, the second dose of methylprednisolone continued, and a therapeutic dose of enoxaparin started. And this is the chest X-ray taken upon arriving to the ICU, and it showed bibasal opacification, of bilateral opacification. This is the CTPA. CTPA was suggestive of bilateral posterior consolidation, similar to cryptogenic organizing pneumonia, and there was no history of pulmonary embolism in the CTPA, and there is a possibility of acute respiratory distress syndrome as well. So her procalcitonin was high with high CRP, so we treated as for bacterial pneumonia. IV broad spectrum antibiotics started, steroids withheld, and her cultures, including bronchoscopy and BAL, all were negative. 24 hours later, our patient made a dramatic recovery with regard to her clinical and neuroradiological profiles. There were evidence of rapidly resolving pneumonia within a period of 24 hours, and we were able to extubate her after 48 hours. So this is the chest X-ray progression of this patient. On admission, her lung fields were clear, and the day when she became acutely breathless, there were bilateral opacification of the chest X-ray, and 24 hours later, while in the ICU, her chest X-ray became apparently clear. That surprised all the medical team. So we managed her as bilateral pneumonia with imminent septic shock. Minimal inotropic support was given on ICU day 1. IV broad spectrum antibiotics completed for 10 days, and there was a marked clinical improvement of our patient. Leukopenia improved, and inflammatory markers came on the downward trend. So we were able to discharge her on oral antibiotics on day 33 of her illness. And then third admission happened. Our patient again developed similar symptom profile following the day after the discharge. And she got readmitted with the same symptom profile. Her physical examination was similar to the previous findings. Lungs were clear, and we noted the cutaneous rash on the trunk, but it was unrelated to the fever spikes. Further into investigation, we noted her to have leukopenia, mild anemia, and this time with relative thrombocytopenia compared to the last admission. Inflammatory markers were still high, but this time PCT was normal. And there we noted a relative drop of fibrinogen compared to the last admission. And her liver profile showed elevated transaminases and low albumin level suggestive of a hepatic involvement. We arranged some specific investigations for her, and the CSF study showed aseptic meningitis, repeated ANA was still high, and the bone marrow aspiration and the biopsy showed hypercellular reactive marrow with abundant histiocytes and without any features to suggestive of hemophagocytosis. So finally, we came to a diagnosis. that is Kikuchi disease complicated with aseptic meningitis, interstitial pneumonitis, macrophage activation syndrome, and acute lupus-like syndrome of Kikuchi's disease. We started her on IV methylprednisolone. 3 pulses were continued. Afterwards, we started her on oral prednisolone 30 mg daily, and HCQ 200 mg was added. With this, her fever settled, lymphadenopathy resolved, inflammatory markers came down, transaminitis improved, D-dimer level and LDH level came down, and the repeat ANA became negative, and we were able to discharge her on day 45 of the illness. So clinic follow-up after 2 weeks, patient was apparently well, fever-free for 2 weeks. There was no lymphadenopathy, no headache, on oral prednisolone 30 mg daily. Looking at investigations, leukopenia has resolved with relative thrombocytosis, ESR and CRP normal, and other markers like serum ferritin, LDH, D-dimer, and triglyceride all came down to the baseline. So this is the clinical experience that we wanted to share with you all, but I would like to share some more in-depth knowledge that we have gained about Kikuchi while doing the survey. Kikuchi disease, also called histiocytic necrotizing lymphadenitis, was described in Japan in 1972 independently by Dr. Kikuchi and Dr. Fujimoto and his colleagues. It's a rare, benign condition, and the pathogenesis is unknown. Pathogenesis, some postulation have made and suggest an immune response of T cells and histiocytes to an infection.
Dineshika, your screen sharing went off.
Kikuchi disease, also called histiocytic necrotizing lymphadenitis, first described in Japan in 1972 and is a rare benign condition, and the pathogenesis is unknown. It suggests a possibility of an immune response of T cells and histiocytes to an infectious agent. Initially described in women younger than 40 years of age and all were previously well. It is frequently reported from Asia. The most common clinical presentation is fever and painful cervical lymphadenopathy. Patients may also have fatigue, rash, arthralgia, and hepatosplenomegaly. Patients with extranodal disease can experience night sweats, nausea, vomiting, diarrhea, and weight loss. Extranodal diseases include skin involvement, hepatosplenomegaly, neurological, and bone marrow involvement. Lymph node involvement usually is cervical and it is localized. Generalized lymphadenopathy is unusual to Kikuchi's disease. Looking at the laboratory criteria for Kikuchi's disease, they are very non-specific. Most patients can have normal complete blood count. Otherwise, they can have leukopenia, atypical lymphocytes, thrombocytopenia, pancytopenia, and in severe cases, anemia of chronic disease. High inflammatory markers can be commonly seen. Elevated LDH is a common finding in Kikuchi's disease thus confusing the diagnosis of lymphoma. The diagnosis is made by lymph node biopsy, and increasing histiocytes without any atypical cells is the most frequent bone marrow finding. Antinuclear antibodies should be performed, and a raised ferritin level is observed, and it may be due to the original disease or with the co-occurrence with adult onset Still's disease or macrophage activation syndrome. There is no effective treatment, and signs and symptoms usually resolve within 1 to 4 months. Severe or persisting symptoms have been treated with glucocorticoids glucocorticoids associated associated intravenous immunoglobulin with apparent benefit. Affected patients should be followed for some years because they can develop SLE, and the recurrences of Kikuchi disease is not uncommon. So looking at the extranodal involvement of Kikuchi's disease, the cutaneous involvement in Kikuchi's disease is relatively common, and it may occur in about 1/3 of patients. The eruptions favors the upper body, such as the trunk, the upper extremities, and the face. The cutaneous lesions can be highly variable, from morbilliform, rubella-like drug eruption-like rashes to papules, plaques, nodules, and urticarial rash. Rare lesions such as leukoplastic vasculitis, erythema multiforme also have been described. Cutaneous Kikuchi disease shares many histological and morphological features with cutaneous lupus erythematosus. Association of discoid lupus and subacute cutaneous lupus with Kikuchi disease also have been reported in some clinical cases. And there is a place of hydroxychloroquine for the treatment of cutaneous Kikuchi disease. The pulmonary involvement in Kikuchi disease is rare, and we have only limited data available so far. Among them, interstitial pneumonitis is the most common pulmonary involvement. There has been one recent case report suggested that Kikuchi disease can be associated with cryptogenic organizing pneumonia and interstitial infiltrate and pleural effusion. All these cases had rapid clinical and radiological response to prednisolone, just as our patient. So these are some of the case reports available to read if you are interested in further. The neurological involvement in Kikuchi's disease is rare. Aseptic meningitis is being the most common presentation, but there are some other uncommon presentations such as acute brachial neuritis, brainstem encephalitis, and kinetic tremors. Resolution occurred without any treatment, but some authors suggested low dose corticosteroids to shorten the duration of the illness. The possibility of aseptic meningitis should be considered in patients with Kikuchi's disease who complain of severe systemic symptoms such as fever and headache during the course of the illness. Also, Kikuchi's disease should be suspected in meningitis of unknown etiology. Macrophage activation syndrome is also associated with Kikuchi's disease. Macrophage activation syndrome, as we all know, is an aggressive and life-threatening syndrome of excessive immune activation. Kikuchi may coexist with macrophage activation. The prevalence of macrophage activation syndrome in Kikuchi is less frequent than the Still's and SLE. There is no significant differences in clinical manifestations between patients with and without macrophage activation syndrome. And patients with macrophage activation syndrome have higher CRP, ALT, and high ALDH level noted in one study. And another study showed only 8% of patients with macrophage activation syndrome along with Kikuchi's disease to have hemophagocytosis in the bone marrow. Talking about the bone marrow in macrophage activation syndrome, bone marrow cellularity can be high, low, or normal, and hemophagocytosis is not pathognomy. The sensitivity of hemophagocytosis is 83% with a specificity of only 60%. So this is one research article published in 2009 in Korea, which in regard to evaluation of macrophage activation syndrome in hospitalized patients with Kikuchi's disease, depending on the NIV classification criteria. Moving on to the role of ANA theta in Kikuchi's disease. Usually ANA is negative in Kikuchi's disease. Up to 45% of patients may have an elevated antinuclear antibody. The significance is of the ANA theta is that a theta more than 1 into 320 has prognostic value for the risk of recurrence and the evolution toward the SLE. There is a specific entity called severe lupus-like syndrome in Kikuchi's disease. We can describe this as a patient who is presenting with fever associated with cervical lymphadenopathy and the lymph node biopsy suggestive of Kikuchi's disease and with ANA positivity and without other criteria. Same thing, just as our patient's clinical presentation. Kikuchi's disease might reflect a self-limited SLE-like autoimmune condition induced by the viral infected transformed lymphocyte. This is a hypothesis now that has been under study. ANA, when we consider the ANA in our patient, when our patient has high disease activity, the ANA theta was high, and when she went into remission, her ANA theta came down. So so whether we can use this point as to use ANA to assess the marker of disease activity is doubtful, but it is worth looking into. Association of Kikuchi's disease and SLE. Kikuchi disease can precede, occurs concurrently, and can follow the diagnosis of SLE. 13 to 25% of patients had association of SLE with the diagnosis of Kikuchi's disease. Arthralgia, cutaneous manifestations, weight loss, positive ANA and dsDNA in Kikuchi's disease significantly associate with the development of SLE. Though Kikuchi's disease is self-limited, we need further monitoring because of that. As we all know, adult onset Still's disease is a rare inflammatory condition, and Kikuchi disease as well as adult onset Still's disease can co-occur. There are limited number of case reports available in the literature, and the main feature in this Kikuchi disease and coexisting Still's disease is that the autoantibodies were absent in all of these patients. And one case report has suggested a rapid response observed with anakinra in a patient who had both Kikuchi and Still's disease. So maybe IL-1 1 beta likely plays a role in both diseases. The prognosis of Kikuchi's disease is benign, self-limited with a favorable outcome. 35% of the patients shows spontaneous resolution within 1 to 4 months. The presence of weight loss, arthralgia, skin lesions, and high ENA theta is associated with the development SLE, as I have mentioned before. So long-term follow-up for such patients is much needed. Recurrence is uncommon. The recurrence rate is about 3%. The predictive factors of recurrence among patients with Kikuchi's disease are the fever and fatigue with extranodal involvement, symptomatic for a rather longer duration, and a positive rate of fluorescence antinuclear antibody. So the studies have suggested fluorescence antinuclear antibody test would be useful in predicting recurrence. HCQ monotherapy or combined with glucocorticoids can be used in preventing recurrence. So why Kikuchi's disease is a great masquerader? Though Kikuchi disease has self-limiting benign course, it mimics the clinical features of many sinister conditions, including tuberculosis, lymphoma, SLE, Still's disease, and macrophage activation syndrome. This can lead to diagnostic confusion for the treating physician. Early recognition and knowledge of its association is crucial to avoid misdiagnosis and mistreatment. So these are my references. And I would like to mention about our team, medical team with Dr. Aruna Gunapala, rheumatology team with Dr. Gunendrika Kasturiratna, hematology team with Dr. Lalendra Gunaratna, and finally, Dr. Amita Pranandu and his team from the respiratory point of view helped in diagnosing this patient. Thank you very much. Do you have any questions?
Yes, Dineshika, thank you very much for sharing your experience. It's a very valuable presentation for all of us. I have a few questions in the chat box. I think some of them you have already answered with your latter part of your presentation. Yeah, what is the relationship between SLE and Kikuchi? I think you were able to explain it. Also, there's a question, why cannot this be SLE with HLH? You answered that question.
Sir, she did not make the SLE criteria other than fever, leukopenia, and there was no other clinical criteria to suggest that she has SLE.
And also, I think she had persistently high ESR with HLH. Sometimes we expect it to come down when it's developed.
Yes.
That is
Actually,
one.
yes.
Gunendrika, yes.
She had high CRP from the beginning. So therefore, we didn't think of SLE at that point.
Yes.
But later on, there was a fluctuation of CRP. So it was very difficult for us to say whether she was having high CRP or not. Later on, we thought that high CRP is due to the activation of macrophages. And only ANA was positive and the double-stranded DNA was negative, and there was no other features to suggest SLE, and repeatedly the C3, C4 levels were normal. So therefore, to her to be that ill, we expected active disease with a low C3, C4.
Yes.
So at the end, we thought it is that, and again that ANA was likely a transient increase because after treatment, it became negative. We did it repeatedly actually to confirm whether this is SLE or not. But we have to monitor because there is an association with Kikuchi and SLE. So we hope to monitor her and follow up carefully to see what is happening in future.
Thank you, Gunendrika. How long are you going to treat this patient now with steroids? And how are you going to withdraw it?
Actually, after the second visit, first clinic visit, she was having all the parameters coming back to normal, and clinically also she was normal. Therefore, we reduced the prednisolone dose to 25 from 30. And we, at the moment, we don't expect to add any steroid sparing agent also. So next visit, we are going to see her what is happening.
So is it, hello? Can
you hear me? Yeah, this is Anke.
So is it
yes, we can hear.
Now, what is the overall diagnosis? Is Kikuchi or is it Kikuchi with macrophage or Kikuchi is mimic macrophage? Because ESR persistently high, no significant cytopenia and early cytosis also there.
Yes.
So what's the overall diagnosis here?
Our clinical diagnosis was Kikuchi complicated with aseptic meningitis, lung involvement, and possible macrophage activation syndrome. Because Kikuchi can be associated with everything, and later on we found it from literature and from the past case reports.
Yeah.
So.
But no hard evidence for the macrophage activation here.
No, they are not saying it's macrophage. Yeah.
Yeah, bone marrow evidence, we can't exclude macrophage activation with a normal bone marrow.
No, exactly, but we usually see very low ESR and very high serum ferritin and serious cytopenia. Here thrombocytosis at the onset, so
yes,
is not
thrombocytosis is inflammatory. We thought at the beginning actually that was the question we had.
Yeah.
She presented with thrombocytosis, but later on she had relative thrombocytopenia. And the CSF confirmed that she had aseptic meningitis.
Yeah, that's agree. Yeah.
So with everything, we for the benefit of the patient, we decided to pulse her with methylprednisolone for a possible macrophage activation as well.
So Gunendrika was discussing this case day by day with me because I had some experience about macrophage activation. What I told, I remember telling her, this is very atypical, this is very atypical.
Yeah.
Because things are not going that way. So this was an excellent case, I think. We really don't know, but she almost had the criteria later on for macrophage activation as well. Though the typical drop in ESR and typical drop in platelets and all, they didn't happen in the typical manner, isn't it, Gunendrika? We were discussing this case every day.
Yes, actually what we wanted is to exclude or confirm the presence of macrophage activation because that was the priority to save her the
because it was a lethal complication.
Serious complications, yes.
Yeah. Then what is the reason for that aggravation, shortness of breath just after steroid, no PE excluded now?
Yes.
Any explanation for that?
Actually there was no pulmonary embolism.
Yeah.
We found that posterior consolidations bilaterally from the free TPA. So since she was critically ill under ventilation, we couldn't continue for a HRCT. HRCT was done later, but that was after about 10 days, ne, Dineshika?
Yes.
Yeah, we gave her pulse as well, and therefore that HRCT was norm. And one other query was, how can she get such rapid radiological resolution of consolidation if it was bacterial pneumonia? Because within 24 hours that consolidation was clear. We thought it's due to intravenous methylprednisolone.
Right.
This was actually a very difficult situation for us to decide.
Yeah, totally agree.
Yes, I am very thankful to the medical team and the respiratory and hematology teams because it was a difficult decision to take on alone because I hope you can understand.
Yeah.
It all happened very rapidly. Within 3 days, she became very ill with low saturation, ventilation, and on the 3rd day, she was clinically much better. We clinically thought it's mostly interstitial pneumonitis.
What is the cyclospore in here? Any place of cyclospore in here?
We thought this is Kikuchi and macrophage activation, and clinically she has improved remarkably, and the parameters have also come down. Not down, actually normal. Therefore, we have no plan to start cyclosporine or any steroid-sparing drug at the moment.
Right. Okay. Thank you very much for your explanation.
I think the lung involvement is probably part of the disease, and steroids were just coincidentally got it on that day, but steroid itself must have got the thing.
We thought the steroid saved her, but we had that high procalcitonin level.
All right, okay.
But there are situations in aseptic inflammation as well. There are situations with high procalcitonin levels.
Okay.
So maybe secondary infection, maybe the disease itself.
Okay, yeah. So I think the time is up for us to close this discussion and very good case history presentation. Everybody enjoyed and learned a lot from that. And so I'd like to thank everybody who joined in and throughout this year, because this will be our last clinical meeting for the year. We'll be having our sessions, as I told you before, in December. And thereafter, Dr. Monica D'Souza will take over the presidency of the college. So I would like to thank everybody who joined you throughout this year to have this very successful clinical meeting, whether it was physical or virtual. We have very good participation. I would like to thank everybody who joined in, all the contributors, as well as our sponsor for the year, Dexametica, its management, and especially Tarindu for helping throughout the year to have a very successful meeting. So thank you everybody for joining today and throughout the year. So we will see next, probably the 8th of January will be our next meeting. Thank you.
Thank you.